Thank you guys for all being brave and being here. We're all passionate about the first trimester, and we want you to become our followers and leaders in this effort. I have no financial disclosures related to this presentation. My institution does receive funds from LabCorp for initiated research on my behalf, but I don't personally get paid by them. And then for those of you who are watching, not all the slides in the syllabus are going to be shown in the talk because of time. So keep your eye on the screen and not on what you have on your laptop because you'll get really frustrated, and I apologize for that. But I always like to share information. So our objectives today is we want to distinguish the sonographic sequence of normal early embryologic development. I want you to recognize early anatomy of the embryo and the fetus and the placenta, but others will go into more depth with that later on. And I want you to be really aware and embrace the definitive criteria for an early pregnancy loss. Now, those of us in clinical medicine know that establishing an accurate due date is critical for good obstetrical care. However, a lot of times our referrals say, 6 weeks check viability, maybe they don't have any information, spotting, and so forth. Keep in mind that up to 2% of babies that are conceived in the United States are conceived by assisted reproductive technologies. And sometimes I'm asked, what is that? That is any technology where you manipulate or handle the embryo or the egg. It doesn't mean taking medication. It doesn't mean IUI. It means that you've, touched the embryo or the egg. And the estimated due date, based on those criteria, the ART-derived criteria, is the most accurate thing you're going to have. And what you do is hopefully the patient will tell you what her IVF provider has given her as a due date, but you look at the age of the embryo. Is it a day 3 transfer? Is it a day 5 transfer? And then you figure out the date of the transfer, and that helps you figure out the due date. A lot of times you won't have that information, so you have to be a sleuth. You actually have to call and find it because it's really important to have. Other methods of pregnancy dating have a lot of variation, or at least a moderate amount of variation. To say the least, we all know that last menstrual period is not robust at all for all the reasons. When did you bleed? Do you really ovulate on day 14? Was it a bleed? And so on and so forth. There's also systematic error. Even when you're using apps, you forget. For some reason, the middle of the month, the 15th of the month, occurs as an LMP date more commonly than you would expect. So LMP is not particularly accurate. What about ovulation? I was taught we ovulated traditionally on day 14, right? Well, in ongoing cycles where you have a live embryo, it's actually a median of day 16. And what about fertilization? Do you guys remember in high school health, they tell you that the sperm can live 7 days in cervical mucus, so timed intercourse is not really going to help you either. There's a delay between ovulation and implantation that's variable. And so we have to keep all these things in mind when we do our modern obstetrical dating, which as imagers, is when we kind of utilize ultrasound crown rump length and compare it to last menstrual period. But again, our crown rump lengths don't take ovulation to implantation variation into account. They don't take differential growth of the early embryo into account. Certainly, we all have different techniques, and there are even different nomograms, so we do have to expect variation. But because we're an ultrasound course, let's talk about the landmarks that you guys are going to see, because that's what we're here for. So the fertilized egg embeds into the decidua, and it grows about 1 millimeter a day. And at 5 weeks gestation, what you see is a rounded fluid collection with an echogenic rim that's slightly eccentrically embedded into the decidua. By 5.5 weeks, you have a yolk sac. And by 6 weeks, you can see the little embryo developing right next to the yolk sac. It's not on the other side of the gestational sac, right? The embryo always has to be next to the yolk sac. And that's when you can first see embryonic cardiac activity. And by 7 weeks, you can determine what's the caudal end and what's the cephalic end. You'll see the amnion in many cases, and you'll see the little limb buds developing. Now, the challenges I see in my practice for my sonographers, my fellows, myself, is at 4 to 4.5 weeks, 5 weeks. That super early, tiny little fluid collection. So here are 2 little fluid collections. You can see they're They have an echolucent center, maybe a little bit of an echogenic rim. They're embedded slightly eccentrically. The opposing endometrial line you can see clearly. Do we remember what that's called? That's the intradecidual sac sign. And that used to be one of the factors that we looked at to say, oh, this is an IUP. However, recently the relevance of that finding has been called into question. And why? It's because you can have a normal IUP without those features, and there's significant inter-observer variation. So what I might think is an intradecidual sac sign might not be what you see as an intradecidual sac sign. And so there's a lot of variation. But I wouldn't throw the finding out, because if you really think you have an intradecidual sac sign, the probability that's an intrauterine pregnancy is 99%. If you don't see it, it can still be a normal IUP. And this was published by a colleague of mine at Brigham and Women's Hospital, Dr. Peter Dubélé, who's actually a radiologist who specializes in early first trimester imaging. And he also happens to have a PhD in mathematics from Harvard. And while we don't want to miss an ectopic pregnancy, obviously, in a patient who's hemodynamically stable, we also don't want to diagnose an ectopic when there isn't one. And so he mathematically figured out that in a patient who had no concerning adnexal findings and has a positive pregnancy test, a tiny rounded being critical, right, fluid collection within the endometrium is 99.5% likely to be an intrauterine pregnancy. It may be a failed intrauterine pregnancy. It may not go on to be viable, but it's not an ectopic. So when you look at these three images, this is a rounded fluid collection, sac-like you might describe it. That's the nomenclature I use, sac-like. I don't want to go 100% that it absolutely is a gestational sac, but it's sac-like, right? But the one in the end there is not sac-like. And why? It's not rounded and it has pointy edges. So here's a case that came into our office last year or the year before, 31-year-old G1 P0 IVF at 5 weeks gestation. And you see this kind of small, funny-looking collection, right? So we did a 3D, and what do we see? It kind of looked to me like it was sac-like. I actually didn't read it. My partner did. But we were thinking probably a little tiny sac. But we were a little bit concerned because it didn't have an obvious intradecidual sac sign. So we actually read it out as a pregnancy of unknown location and recommended serial HCGs. But the referring provider decided that that wasn't possible and treated the patient with methotrexate for a presumed ectopic. So you can guess what the follow-up story is, right? I see Elizabeth shaking her head. I agree with you. 9 days later, her HCG is rising. And what do you see? You see a pregnancy in the uterus, and in this case, it wasn't a viable pregnancy, but still, this should not have happened. In most cases, we don't do a discriminatory zone anymore. I mean, yes, if you're 3,500, 4,000, that may be a consideration, but lower levels need to take into consideration what the serial change is, because we don't want to treat a possibly normal intrauterine pregnancy with methotrexate and cause harm for a lot of reasons. Obviously, it makes us feel terrible, right? But it also can end us up in court and we can lose a lot of money. Now, the other thing I want you to look at when you look at the very early pregnancy are the decidual layers. I want you to be aware of the decidua basalis, the decidua capsularis, and the decidua parietalis. If you see this little sort of hypoechoic collection around the gestational sac, that's not a subchorionic hematoma. That's one of the more common errors that my really residents and fellows make. They see anything out there, they say, oh, that must be a bleed. But it's not. It's just that the inside of the endometrium hasn't been completely obliterated yet. So we talked about the first thing being that tiny fluid collection. Every guideline, for some reason, talks about the mean sac diameter. It's measured in the area of the lucency, not the surrounding echogenic material. It is not accurate for dating, although it may help to determine the interval of follow-up for the next scan. I personally don't measure it, but it's certainly in every guideline. The yolk sac is the first extraembryonic structure that becomes visible by transvaginal sonography, and it definitively confirms an intrauterine pregnancy, 100%, right? You know it as a thick-walled structure with an anechoic center. Keep in mind for your anatomy that it's outside the amnion, and that's really easy when everything looks good, but let's say it's not so clear. You really want to know what the anatomical relationship is. And the yolk sac provides a multitude of supportive functions until the placenta takes over. And Paula Woodward, who's an amazing radiologist in Utah, calls it the embryo's backpack until the placenta takes over. So I think that's a really good analogy. The embryo itself develops right next to the yolk sac, and you can see it here at 6 weeks gestation. That's when we first see the heartbeat that you want to demonstrate by M mode or video clip. If you can't see it by M mode, that's okay. A video clip will work just fine. And it's called the diamond on the ring because it should be, again, I can't stress enough, right next to the yolk sac. Why do you think it should be? Why is it not across the other side of the gestational sac? It's because anatomically, the embryo is attached to the yolk sac by the vitelline duct, so it can't be on the other side. And there you can see an example of vitelline ducts. A little later in gestation, you'll start seeing some early anatomy, and Dr. Benoit will give you an amazing talk, I think he's next, on the early anatomy. But you can see the developing ventricular system. You can see the limb buds start to form. Those are all features that we look for. Again, look at where your decidua basalis is. Keep an eye on where you're implanted. And that's important because when we talk on Saturday about cesarean scar pregnancy and placenta accreta spectrum, something that's going to help you differentiate that is going to be where your decidua is. As we get farther along, you can see the amniotic cavity expands, the amniotic fluid is echolucent, and the extracelomic space around the embryo is filled with these echoes, and they provide a variety of nutritive functions and a reservoir for the fetus. We can see the hands and feet really very clearly. Now, you're all aware of the physiologic umbilical herniation that occurs between 8 and 12 weeks. We want to be super careful not to mistake this as an abnormality. So what happens is as the bowel elongates, right, it gets too big for the peritoneal cavity. So it goes out into the base of the umbilical cord, it rotates 90 degrees, and then it rotates another 180 degrees as it retracts back into the embryo or fetus. It becomes a fetus at 10 weeks. And here you can see a scan that my sonographer brought to me and was a little bit concerned about the prominence of that herniation. You know, could it be an omphalocele? Could it be something else? Well, one of the tricks that I use is I measure it. And if it's less than 7 millimeters, I feel reassured that that's a normal finding. On the other hand, look at this little fellow, 9 weeks. You do a crown rump. Looks kind of awkward, right? You look at that anterior abdominal wall or even the whole abdominal wall. It's kind of poofy. So you get out your transvaginal probe, and anybody who works with me knows that I consider the probe your friend. I use it a lot. And you see the outpouching. Didn't give me a lot more information in this particular instance, but look what happens when you look at it in an axial section. The abdominal circumference should never be equal to the herniation that you see. And in this case, it was almost 8 millimeters. And this is a nomogram showing crown rump length versus the expected or the maximal width of a herniation, and you can see it was way too high. And when this fetus came back at 12 weeks gestation, it clearly had a large omphalocele. Why do we care that we made the diagnosis early? This lady was able to go, instead of getting non-invasive prenatal testing, she actually had diagnostic testing. She had a CVS. So by the time we made a definitive diagnosis, she had all the answers she needed to make a decision. So the liver should never be out. I'm going to skip over crown rump lengths because I'm sure all of you do them quite regularly. They're most accurate early in the gestational age window. It's one of the easiest things we can do early on. However, it gets hard. Those of you who do NTs know those little like 11 to 14 weekers can be really difficult. They extend, they flex, they do all kinds of things. But we really need our measurements to be accurate. And so Dr. Abu Hamad in his residency curriculum has published some of the metrics that we should all meet so that the crown rump length that I take is the same as the one you take is the same as the one that your neighbor takes. Now, how do we establish the due date? We do less menstrual period and ultrasound. And when do we rechange that? When do we modify the EDD based on LMP? It occurs when there's a discrepancy between the ultrasound dating and the LMP of more than 5 days at less than 9 weeks and more than 7 days at less than 14 weeks. Once you've established your clinical dates, you should almost never change them unless something really weird comes up. In the 30 years I've been practicing, it has happened to me once. So here's a patient who came in. She had had a 6-week scan. She came in for first trimester anatomy scan, and the crown rump length lagged the menstrual dates by 8 days. So what should we do with this? She'd already had a low-risk cell-free DNA. Should we redate the pregnancy? Did we make a mistake? Is there other biometry you guys want to have? Anything else you want to do? So my sonographer decided to do a 3D transvag, and look at this. This was an acrania and encephaly sequence. And the reason that the crown rump length lagged the gestational age was it didn't have a cranium. And in this case, crown rump length lagged menstrual dates by more than 7 days. You can see it was a super busy day in ultrasound, and I'm telling you real life stories here. Maybe I shouldn't share all our dirty laundry, but there were 10 in the box. We were an hour and a half behind. The sonographer came up to a colleague of mine and said, it's an early anatomy scan, but they're too early because we don't do them before 12 weeks. And he said, fine, go ahead. Later, reads it, redated the pregnancy, asked for come back in 2 weeks. Can you guess what the problem was? It was a communication problem. So in this case, the crown rump lagged IVF dating by the amount of time it said. So that's a problem, right? You can't, if you're lagging your IVF dating, you have to be suspicious that there's aneuploidy or there's something else going on. So she came back 2 weeks later, and these are the images we see. Does this hit you as something awkward? What do you see when you see this fetus? What about your 3D? Anything catch your eye? What do you think about the size of the head and the size of the body? Discrepant, right? That's an Aunt Minnie for digynic triploidy, meaning the extra set of chromosomes coming from the mom. And if you look back at the image at the top here, you can see that we could have seen that had we really communicated properly. You could see that at what was 10 weeks, 6 days. So what about multiples? What do we do with multiples? You come in, one is bigger, one has a crown rump of 67, 13 weeks, the other's 51, 11 weeks, 6 days. Which one should we date it by? Well, by convention, based on limited data, we base it on the largest one. And why is that? Because it reduces the risk of missing fetal growth restriction. And so our societal guidelines, ISWOG, the Society of OBGYN in Canada, the AIUM, all recommend that. However, keep in mind, there are opposing opinions. So I always say, keep your eye on the ball because it may change. But right now, we're dating by the largest fetus. And you don't need to use twin-specific nomograms because it's not clinically relevant and it makes no difference based on placentation. So let's talk about the diagnostic criteria for non-viable pregnancy. Historically, some of you who've been practicing before 2013 know that we had a completely different set of standards, right? It was alive by 5 millimeters. You had to see a heartbeat. The sac size had to be 16 millimeters. And all of a sudden in 2013, there was this publication, again by Dr. Peter Duboulay and other colleagues from the Society of Radiologists and Ultrasound that said, not so fast, people. And the reason is the initial studies were based on small series. And there now is a more conservative approach that takes several things into consideration. It takes into fact that we want 100% specificity. Like we never want to call an embryo dead when it's not, right? So you have to be 100%. There's also inter-observer variation. So what you might say is 5 millimeters, I might say is 4, and somebody else might say is 6. So in order to account for all of these things, they devised a new set of recommendations. And these are published in the New England Journal of Medicine. And I would say cut this out and put it on the wall of your ultrasound suite, because your referring providers are going to come and ask, why are you being so conservative? Why can't you call it? You should be able to call it. Well, you can't. And this also has been a source of some medical legal issues. So when we look at this paper, they divided it into findings that were diagnostic, absolutely 100% of a pregnancy failure, and findings that were suspicious but not 100%. So the diagnostic criteria is if you have an embryo with a crown rump length of 7 millimeters and you don't have a heartbeat, that is a demise. Now, that takes into account inter-observer variability, and that measurement has 100% specificity and a positive predictive value of 100%. If your crown rump length is less than 7, 4, 5, 6, you're suspicious. Because typically, right, those of you who scan, you can see the heartbeat little flutter before you even see the little embryo. So you'd be suspicious, but you can't be diagnostic. And these are results from a prospective multi-center observational trial looking to validate the information in Dr. Dubilay's New England Journal article. And what they did is they looked at crown rump length versus gestational age and dates in embryos that did not have cardiac activity, and they looked at outcome. Those that were eventually had a heartbeat are in orange, and those that are in blue were never viable. And what you can see is that you have a certain number of embryos that were 6 millimeters that ultimately became viable. And therefore, given the inter-observer variation, they confirmed that 7 millimeters was an appropriate standard. So if you have an embryo that's littler than that, you need to follow up in 7 days or more. Now, don't let opportunity pass you, because you guys are stars, right? You want to really help the patient, your referring providers. So here's an embryo who comes in who's not alive at 20 millimeters, so clearly a demise. What else do you see when you look around? Look at that placenta decidua. It looks really cystic, right? This is a typical example of a partial molar pregnancy, which is diandric triploidy, which meant the extra chromosome set came from the father. You can also, if you have time, and I'm not saying you need to do this, you can do 3D. It may give the patient some answers. Here you can see a thickened nuchal translucency, and you can see that the contour of the lower part of the baby is completely abnormal, right? What about this one? Look at the proboscis. It may be only 8 to 9 weeks, but it clearly is not normal. Or this one that has a bilateral facial cleft going all the way up to the orbits. That's a Tessier cleft. And the one on the right, all of you can see that the outer contour, this is a conjoined twin, right? Throw on your color and you can even make some pretty pictures of that. So the diagnostic loss of a mean sac diameter of 25 millimeters or more without an embryo is also definitive for an early pregnancy loss, and that's 100%. In this case, the inter-observer variability is 19%, so we have to be careful. We measure more different than we do even on crown rump length. If it's smaller than that, if it's between 16 and 24 millimeters and you don't see an embryo, you can be suspicious. Now, the one thing I would say, and the controversy that we end up looking up, it's that size without an embryo. They don't say anything about membranes and yolk sacs, right? It's specifically no embryo. And again, in the same study that I showed you, if you look at mean sac diameter and gestational age, those who are viable and non-viable, the cutoff is reasonably at 25 given the inter-observer variability, and that's the prospective validation. So you follow up in 7 days or more. So there are also time-based intervals. If you see a gestational sac and you don't know if it's viable or not, if you repeat it in 14 days and you have no embryo with a heartbeat, that's not a viable pregnancy. You can say that's a pregnancy loss. On the other hand, 7 to 13 days, you can be suspicious, but you can't be definitive. Similarly, if you see a yolk sac, 11 days or greater, you don't see an embryo with a heartbeat, Embryo alone doesn't count, right? Embryo with a heartbeat, you can say that it's definitively demised. But before that, you can only be suspicious. And those of you, how many of you guys see early pregnancies all the time? How do patients react when you give them that gray news? They're worried, they're concerned. We have to manage their expectations because at least in my practice, they come back at 7 days and you have nothing you can say except for, gee, I can't tell you yet. You need to wait another week. So we have to be careful to manage expectations. Now, I did put a reference by Preisler, that same study I showed you, because you can actually triage that interval of observation based on the mean sac diameter. If it's greater than 12, you can follow it up actually in 1 week. If it's less than 12, you need the full 14 days. We personally don't do that in our lab. I think we'd make too many mistakes probably. But if you have a small, focused practice, you may be able to do that. If you have twins with one demise, generally it's associated with a good prognosis. However, it can be discordant for cell-free DNA results, both for your autosomal trisomies and your sex chromosome disorders. So that's another thing to think about. So here's your scanning Monday morning. You go back to your practice and you see this clip. What are you thinking, right? Well, you see an embryo with a heartbeat, right? And what's that over in the corner? Is there another little one? 7 millimeters. Does it have a heartbeat? You don't really see one. You throw on color, and typically you might not do that, but in a monochorionic pregnancy, it's certainly something you should think about. You throw on your 3D and you can say, wow, one is certainly bigger than the other. So what are we seeing? Like I said, monochorionic diamniotic twins, discordant crown rump lengths, right? One has a heartbeat, one, I don't know, can't see it, but flashes a little color. What do you think? What are you going to tell your referring provider? Is it a missed, is it one embryo, a vanishing twin? Yes, no, who knows? Is it early monochorionic twins and they're going to catch up and it's probably going to be fine? Or are there other ideas that you have? Well, if you're not really sure, the next thing you want to do is just follow up in 2 weeks, right? So come back in 2 weeks and the thing is grown. So anybody recognize what this is now, that this monochorionic twin without a clear heartbeat has grown? It's a cardiac twinning or twin reversed arterial perfusion sequence. And what's important is that you didn't just assign that little one that was small with no heartbeat as a vanishing twin, because it's an acardiac twin and that'll grow. Now that same paper from Dr. Dubélé for some reason lists these particular signs for suspicious for early pregnancy failure, and I decided to stay with the theme. There are many others, but certainly if you see a yolk sac and an amnion without an embryo, you should be suspicious that it's an early pregnancy loss and follow it up in a week. However, be careful. Remember, the amnion and yolk sac are going to be next to each other. If you see the image you have on the right, what should that make you think of? You have two equally sized, far apart, circular structures. Those are monodi twins. Those are two yolk sacs that are totally fine. Now, I will admit, having been the person who wrote the original case series with my partner, Dr. Benacerraf, in 1992, that only about 85% of the time does the number of yolk sacs suggest the number of amnions. It's not 100%. But if you see an image like that, do not think that that is suspicious for an early pregnancy loss. The other thing is a small sac. If it looks like you're in a studio apartment, even with a heartbeat, that puts you at increased risk, maybe 40 to 90% risk of miscarriage. So we certainly follow up those patients. And lastly, in their paper, they use a large yolk sac. We don't actually use that because I don't think it's super predictive of anything, but there's certainly literature to support that out there. So Monday's a busy day for you. In the afternoon, this patient comes in, 6 weeks, dating scan, maybe she's had a little bleeding, you see a good heartbeat. What the heck are you seeing? Does she have a chorioangioma? No, because she doesn't have a placenta yet, right? Does she have a partial mole? Doesn't quite look like it. This is what we call a chorionic bump. And a chorionic bump is this focal protrusion of the chorion into the gestational sac that's contiguous with the surface of the chorion. And it's thought to possibly be due to arterial hemorrhage from the intervillous space. It's heterogeneous. It has those internal hypoechoic areas. It has sharp angles. Can you see the little vascular flow? Can you see how it's like swirling around there? It's thought to be due to decidualized endometrium with necrosis and hematoma. And this is what it would look like on 3D. You can see the protrusion from the chorionic plate or the bump and the other. This is like getting in there and looking at it in 3D virtually. Now, it does increase the risk of miscarriage 2 to 4-fold, but if the embryo has heartbeat, most of them do really well. There's no relationship between the size of the bump and the outcome. And this is what a bump looks like compared to a subchorionic hematoma, which is under the chorion. And here again, you see that same fetus at 12 weeks, it's still there. And by 20 weeks, it's resolved. So I don't have much time, but I really feel obligated to talk about ALARA just briefly. It's your responsibility as an end user to practice in compliance with ALARA all through the first trimester, right? So you want to use your lowest acoustic output to obtain diagnostic quality images, because ultrasound has the potential to elevate temperature in the tissue being scanned, and an elevated temperature potentially can result in teratogenic effects. So you want to be observant. And you observe it by watching the thermal index, which is the estimate of that potential increase in the temperature being scanned. And it depends on what you're scanning, whether you're scanning bone because it absorbs more energy or soft tissue. And in order to find out what you're doing, you have to monitor your output display standard, which is typically in most systems on the top of your screen. You want to consider your exposure and dwell time. You don't want 18 people scanning the patient. And you want to use your ultrasound prudently. You don't want to do, let's just look at the heartbeat. Let's go check. You really want to do it for medically indicated procedures. Your thermal index, as I mentioned, the formula is based on when you scan. Soft tissue is used for GYN and OB at less than 10 weeks. And once ossification happens in the fetus, once it becomes a fetus at 10 weeks, you use your thermal index for bone. And it's recommended that the ratio be less than 0.7 for extended scanning. So when mom asks you, can I hear the heartbeat early on? You explain to her why you don't feel comfortable doing that. You won't do that. This is an internet image. You don't want to be showing pictures. You want patients showing their pictures with you doing Dopplers. However, in the talk that I'm going to give and other people are going to give throughout this conference, we're focused on first trimester anatomy, especially at the end, right? There, you can use your color. You use it because it is medically indicated to give you a good quality diagnosis. But you do monitor your thermal index and make sure your ODS is seen on your image up there. And thank you. I hope that's helpful to you.